So medical treatment for visceral disease is generally not effective as sole therapy. So before you go to the OR for treatment of visceral stenosis, you want to consider aggressive resuscitation with restoration of adequate urine output. You want to correct the electrolyte abnormalities and the metabolic acidosis and consider IV antibiotics. In patients with chronic mesenteric ischemia, you can consider TPN. Nowadays, though, I think with endovascular therapy, if you're going to stent, the TPN is not so critical because once you get the stent in, you can just start feeding them. So endovascular therapy is often for patients with chronic mesenteric ischemia. Restenosis and symptomatic recurrence rates remain relatively high. The benefits are that there's reduced mortality and morbidity and an improved quality of life. There's worse long-term vessel patency with an increased need for reintervention. Usually for the SMA, the brachial approach is preferred. For the celiac, most often femoral access works okay, but I think it's important to look at the CAT scan and kind of get the direction of the artery and plan your approach accordingly. If you got a sharp pitch, you might be better off coming from the arm. If it's flat and a long branch before it splits, the femoral approach will work just fine. Primary stenting is recommended, and usually most people use a balloon expandable stent. It gives you better control and more radial force. Retrograde stenting also works, as oftentimes you have a patient with acute bowel ischemia that goes to the OR for the laparotomy and to actually evaluate the bowel. And while they're doing the resection, you can go in there and you can put your stent in retrograde. The benefits are that the mortality is a lot lower than with open bypass. So again, the advantages are you can evaluate and resect bowel as necessary. It also decreases the operative time compared to an open bypass. The disadvantages are you can injure the vessel, you can cause a dissection by trying to break through the plaque, and then there's obviously in the future a need for restenosis due to intimal hyperplasia. So if you have to perform an embolectomy due to embolism, you can do a transverse arteriotomy distal to the area of obstruction. You pass a Fogarty balloon up until all clot is evacuated and you got proper inflow. If there's a lot of plaque, you can convert to a longitudinal arteriotomy and then endarterectomize the artery and then patch it closed with the vein. So the exposure to the celiac is best achieved through a midline laparotomy. The SMA is usually found at the base of the transverse colon and also lateral to the fourth portion of the duodenum. If you're going to do an operation and you're already in there, multi-vessel revascularization improves your long-term success. Most people generally tend to use prosthetic grafts due to better patency. If you need to use a vein due to infection or risk of infection, the femoral vein is better than the saphenous vein. Most people use Dacron graft. So for chronic mesenteric, your open options are, if you just have an orificial lesion, you can do a transaortic endarterectomy. You can do a retrograde mesenteric bypass or even an antegrade bypass. The antegrade bypass is excellent durability, good symptom-free survival. It's best suited for elective revascularization, and the main thing is that the bypass originates in the supraceliac aorta above the lesions. The advantages are that usually the supraceliac aorta is not involved with disease, with plaque. The limbs also follow a more natural course and they maintain prograde flow. Retrograde bypasses, it's not any better or any worse. The bypass originates off the infrarenal or aorta or iliac artery. The biggest advantage is that it's got a lower incidence of postoperative complications than 30-day mortality, and also it's a much easier exposure to dissect out the infrarenal aorta or the iliacs. The patients have less hemodynamic instability and the potential for distal embolization is lower. The main disadvantage is that since you're tunneling it up, it can flop, it can bend. If it's not laid out properly, you can kink the bypass graft. So other stuff, there's median arcuate ligament syndrome and non-occlusive mesenteric ischemia. The treatment for median arcuate ligament is you gotta lyse the band. And then for NOMI, the main treatment is you gotta fix the patient. In rare cases, you can do a selective angiography and drip in a vasodilator. But ultimately, if they're on pressors and they're sick, you gotta fix them before their gut's gonna improve. So renovascular disease, you can do an open repair, you can do aortorenal bypass. Usually it's the most versatile. You can do an aortorenal thromboendarterectomy, and it's good for aortic disease that involves both orifices. And in rare cases, you can do a renal artery implantation, which is good for children. That often comes up on the written boards. Percutaneous intervention is probably what most people do these days. Balloon angioplasty and stent for osteal lesions. And as we heard in the last talk, balloon angioplasty is sufficient for FMD.